Our next talk will be on liver disease in pregnancy and will be delivered by Professor Muhammad Sultan Khuroo, who is the Director and Digestive Disease Center, Dr. Khuroo Medical Clinic, Srinagar, Kashmir, India, former consultant and head gastroenterology and liver transplantation, King Faisal Specialist Hospital and Research Center, Riyadh, Saudi Arabia. Professor Khuroo has had more than 300 research articles under his name and is a world-renowned gastroenterologist. He will present his talk through Zoom. Are you ready?
Disorders which affect pregnant women. I have been fortunate to traverse many journeys to explore the unknown and to stamp landmarks in biomedical research. The focus of all this has been to advance knowledge, relieve human pain and suffering, and save lives. As a hepatology student, I reported on 16 cases of Barchari syndrome following pregnancy. Mr. Chairperson, sir, today I feel honored to be invited to deliver this state-of-art lecture on liver disease in pregnancy to this August meeting of distinguished hepatologists of Pakistan. I shall focus on current understanding and newer thoughts on the challenging clinical issues related to panorama of hepatic disorders which affect pregnant women. I have been fortunate to traverse many journeys to explore the unknown and to stamp landmarks in biomedical research. The focus of all this has been to advance knowledge, relieve human pain and suffering, and save lives. As a hepatology student, I reported on 16 cases of Barchari syndrome following pregnancy amongst a large cohort of 105 patients with Barchari syndrome. The clinical, biochemical, radiological, and hemodynamic studies on these patients identified and established Barchari syndrome following pregnancy as a distinct clinical entity and continues to be so as of today. Sir, I feel nostalgic to inform this distinguished audience that discovery of hepatitis E, a remarkable human interest story, did start with my extreme belief that epidemics of jaundice and resultant mortality in pregnant women had a hidden saga and needed to be uncovered. I spent decades uncovering this unholy alliance and would address this in detail in tomorrow's lecture on hepatitis E. In a normal pregnancy, many physiological and hormonal changes occur within the human body, some of which may mimic those seen in women with advanced liver disease. It's imperative for us as clinicians to recognize these and their temporal relationship with duration of pregnancy to avoid errors in clinical judgment while managing liver diseases in pregnancy. Liver disease in pregnancy is poorly studied while being pretty common and pose a diagnostic challenge both to obstetricians and hepatologists. It continues to be a significant threat to the mother and the baby. In our community, around 25% maternal deaths and 13% neonatal deaths are associated with jaundice in pregnant women. Hepatitis E is a major component of such deaths, as 58% of deaths with acute liver disease in pregnancy are caused by hepatitis C virus infection. A high degree of suspicion with early intervention is necessary to save the mother and the baby. Pregnancy-related liver diseases encompass several syndromes unique to pregnancy. In addition, pregnancy can occur in patients with pre-existing liver disease, and of course, coincidental liver disease may affect pregnant women. Each group poses special clinical, diagnostic, and therapeutic issues which need to be unraveled in detail. There is always a hesitancy with the clinicians to apply some important and necessary invasive diagnostic tools in pregnant women, understandably, to avoid damage to the fetus. Now, several societies have issued guidelines to this, and published data have shown that invasive tools can be safely applied if guidelines are followed. Generally, radiation exposure should be avoided in the first trimester and limited beyond that. MRI, magnetic field, and computer-generated radio waves are safe, while use of the gadolinium is contraindicated. Endoscopies along with ERCP and premedication with mepridine and propofol can be used safely in and beyond second trimester of pregnancy. Hyperemesis gravidorum is a commonly encountered entity in the first trimester, is not a true liver disease per se, but earns its inclusion here as a subset of such patients have elevated liver enzymes of unknown cause with normal liver imaging and pathology. Patients present with severe intractable vomiting, dehydration and its consequences, and weight loss. Patients can develop esophageal tears and rupture, and develop vernix and encephalopathy as a result of thiamine deficiency. High levels of HCG and estrogen stimulate upper GI secretions, leading to vomiting, and affect PSH receptors, causing a temporary biochemical hyperthyroid state. Preterm births and fetal growth retardation are known to occur in hyperemesis. Genome-wide association studies have identified two loci which correspond to two genes, namely GDF15 and IGFBP7, both of which known to be involved in placentation, appetite, and starvation. Both GDF15 and IGFBP7 proteins are upregulated in hyperemesis and cause nausea, vomiting, nutritional deprivation, and weight loss, with consequent neonatal and fetal events. Management of hyperemesis centers around monitoring, best done by validated scoring, replacement of fluid and electrolytes ideally through IV line in an inpatient setting, replacement of thiamine with folic acid to prevent vernix, and control nausea, vomiting, and retching. Pyridoxine with doxylamine is the first line of therapy, followed by several antiemetics, including ondansetron. Corticosteroids started parenterally and then orally for a few weeks may be necessary and show gratifying results. Intrahepatic cholestasis of pregnancy belongs to a group of cholestatic syndromes caused by mutations of the MDR3 gene and consequent defective MDR3 protein. MDR3 is a canalicular phospholipid translocator under the title of philipases. MDR3 protein translocates phospholipid into the bile, which binds bile salt into micelles. The absence of phospholipids in the bile leaves naked bile acids, which cause varying degree of inflammation and necrosis in the cholangioles and consequent cholestasis. Intrahepatic cholestasis of pregnancy is a relatively common disease encountered in our community and presents as severe cholestasis in the third trimester and is characterized by elevated liver enzymes and elevated bile acids. Once other conditions of cholestasis are excluded, management is based on UDCA therapy and most of such patients do well. Some patients may need additional rifampicin therapy. Preeclampsia-associated liver disease and HELLP syndrome are caused by abnormal placentation due to shallow invasion and differentiation of the trophoblast and incomplete spiral artery invasion. Consequent to this, placental ischemia and infarcts lead to release of vasoactive substances, namely nitric acid, prostaglandins, and endothelin. Endothelial dysfunction causes the endothelial deposition of platelets and thrombi and consequent thrombocytopenia, DIC, hepatic necrosis, and hemorrhage. HELLP syndrome complicates preeclampsia in 12 to 20% of cases, though a subgroup of HELLP may occur in patients without preeclampsia. Patients present in the second and third trimester with right epicaudal pain, nausea, vomiting, and icterus. intravascular hemolysis as evidenced by schistocytes and Barr cells on peripheral smear and elevated liver enzymes, a 3 to 5-fold elevated liver enzymes, and low platelets are hallmarks of this syndrome. It is essential to perform adequate hepatic imaging to evaluate for hepatic infarcts and parenchymal and subcapsular hematomas and liver rupture, as is seen in these 4 cases from my clinic. Liver rupture is a life-threatening complication and is a result of leak from a large subcapsular hematoma. Management of HELP syndrome is based on rapid delivery of placenta and the fetus. To accomplish this, we need to treat high blood pressure, convulsions, and DIC, and attain fetal lung maturity if fetus is less than 34 weeks of age. Following delivery, there is clinical improvement within 48 hours, though patients need to be observed in a high dependency area for possible worsening of the maternal symptoms. Management of severe hepatic complications, namely large infarcts, hematomas, and impending and obvious liver rupture, need management with urgent angiography and surgery as the case may be. Acute fatty liver pregnancy is a mitochondrial cytopathy with an inherited defect in the mitochondrial beta oxidation, resulting in accumulation of unmetabolized long-chain fatty acids in the fetus and placenta, which cross over to the maternal blood and cause hepatic microvascular steatosis and organ dysfunction. A mutation in one or both alleles of alpha unit of trifunctional mitochondrial protein causes defective enzyme long-chain 3-hydroxyacyl coenzyme A dehydrogenase deficiency, which impedes the conversion of hydroxyacyl to ketoacyl, causing defective beta oxidation. 20% of neonates born to mothers with acute fatty liver pregnancy have defects in the beta oxidation, while mothers of neonates with beta oxidation defects have an 80% chance of acute fatty liver pregnancy. Acute fatty liver pregnancy is rather an uncommon entity, presents in the 3rd trimester or postpartum period with mild non-specific symptoms, which if unrecognized progress rapidly to acute liver failure associated with multi-organ failure. Ultrasound shows fatty bright liver parenchyma, and if biopsy is done, characteristic foamy liver cells on oil red O staining clinch the diagnosis. Management of acute fatty liver pregnancy is centered around early recognition, maternal resuscitation, and urgent delivery of the placenta and fetus, regardless of the fetal age. Following delivery, maternal intensive supportive care in a multidisciplinary team is required. Plasma exchange may help to hasten hepatic improvement and decrease intensive care stay. Acute fatty liver pregnancy often resolves with delivery of the fetus and the placenta and rarely needs liver transplantation. Fetal mortality rates are around 20%. All children should be screened for at birth and monitored for symptoms of LCHAD deficiency. Chronic HB infection is a common coexisting illness encountered in pregnant women and has excited strict uniform criteria by many societies. It is recommended that all pregnant women should be screened for hepatitis B status. Apart from few self-limiting flares in liver enzymes, there is no adverse effect on the liver functions. However, in view of high perinatal transmission to neonates and its long-term consequences, it is necessary to use proper guidelines to block it by one or more of the strategies, including antiviral treatment of the mother in the 3rd trimester, hepatitis B vaccination with or without hepatitis B hyperimmunoglobulin to the neonates. Tenofovir and tervabidine are recommended antiviral drugs in patients with hepatitis B high viral load. Pregnant women following in the high-risk group should be screened for hepatitis C virus. Pregnancy confers little or no added risk to the mother in the context of chronic hepatitis C virus infection, nor any impact on her long-term prognosis regarding hepatitis C virus infection. The risk of transmission to the fetus is low, around 3 to 10%. It is recommended to limit invasive procedures on the fetus to limit HCV transmission. Introduction of direct-acting antivirals has revolutionized the treatment of HCV infection, and if treatment is indicated, it is recommended to start these drugs in the second and third trimester of pregnancy. Pregnancy in cirrhosis is heralded by several fundamental facts, which include reduced fertility, adverse fetal outcome and hepatic decompensation in 10%, and worsening of portal hypertension in 30% of others. Varicose bleeding is a dreaded complication that could be fatal and occurs in second and third trimester and during delivery in patients with pre-existing varices. All pregnant women with cirrhosis should be screened for varices in the second trimester, and those with high-risk varices should be treated ideally with varicose band ligation. Beta blockers are class C drugs, but are generally safe if indicated. Varicose bleeding in pregnant women can be treated with octreotide and band ligation. Pregnant women with autoimmune chronic active hepatitis are known to develop disease flares during gestation or postpartum period. So pregnant women with autoimmune chronic active hepatitis should be continued on corticosteroids and or azathioprine as the case may be. Patients with cholestatic liver diseases do show worsening of itching, and such patients must be continued on UDCA therapy. Patients with non-alcoholic fatty liver compared with other groups during pregnancy more often show gestational diabetes, hypertensive complications, postpartum hemorrhage, and preterm births, and need strict monitoring. Fertility can take up to 12 months to return to optimum in patients post-transplant, depending on the mother's pre-transplant health. Specifically, live births expected in over 70% of conceptions. Acute cellular rejection is more common in first year post-transplant and is recommended that pregnancy be delayed for 1 year after transplant. Immunosuppression therapy should be continued, and any risk to the fetus is far outweighed by the risk to the rejection and graft failure. Mycophenolate is associated with embryonopathy and should be discontinued in both female and males with 6 months washout prior to conception. Of the liver masses, small hemangiomas are common and need no surveillance during gestation. However, a large cavernous hemangioma can grow and need regular screening and, if possible, treatment before conception. Focal nodular hyperplasia is found in 3% of population, and pregnancy has no adverse effects with good clinical outcomes. Hepatic adenomas have a high risk of growth during pregnancy owing to the hormonal stimulation, and ultrasound monitoring is recommended during pregnancy. Large hepatic adenomas or those showing rapid change in size in young women of childbearing age should be treated by surgical and radiological intervention. Acute viral hepatitis is the commonest cause of jaundice in pregnant women worldwide. In developing countries, hepatitis E virus is the dominant cause, followed by hepatitis B virus. It is recommended that all pregnant women presenting with acute hepatitis syndrome should be tested for common etiologies, namely hepatitis A, B, C, and E. Pregnancy does not have any significant effect on the course of hepatitis A, B, and C infections. It is recommended that pregnant women with non-A to E serology should be tested for atypical viral agents, including herpes simplex virus. Pregnancy increases the maternal severity of herpes simplex viral infection type 1 and 2 with typical clinical, imaging, and radiological features. It is recognition and early treatment with acyclovir are important to manage this otherwise fatal syndrome in pregnancy. Pregnancy is a risk factor for Budd-Chiari syndrome. A similar risk factor exists for on long-term oral contraceptives. Patients present with sudden onset of abdominal pain, jaundice, and mastocytosis, and hepatomegaly and prominent veins in the abdomen and flanks. A subset of such patients show progressive deterioration of liver functions, develop encephalopathy, and die. Interventional treatment, namely balloon dilatation of hepatic vein, webs, or localized strictures of the hepatic veins with stenting is usually curative. This patient with hepatic vein web had rapid resolution of liver disease following balloon dilatation of a localized web at the mouth of right hepatic vein. We have been treating patients with extensive hepatic vein and IVC thrombosis with transjugular intrahepatic photosystemic shunts with gratifying results. Patients with advanced liver disease and liver failure are considered for liver transplantation. Cholecystectomy is common in pregnancy and second most surgical emergency. Ultrasound should be the imaging of choice with 95% sensitivity for diagnosing gallstones. Symptomatic cholecystitis should be managed conservatively. However, early surgical intervention with laparoscopic cholecystectomy is recommended in severe cases or recurrent cases in view of the possible biliary or pancreatic complications. Biliary pancreatitis, symptomatic cholelithiasis, and cholangitis have poor maternal and fetal outcomes without intervention. ERCP, if indicated, can be safely done with limited fluoroscopy time, external fetal shielding, and adjusting the patient's position. Here I have listed all possible drugs or drug formulations that are commonly used in liver disease and pregnancy. Most of the drugs used in hyperemesis gravidorum are generally safe for use. UDCA and rifampicin for intrahepatic cholesterol pregnancy can be used with safety. Methyl-dopa is the first drug of choice for hypertension in pregnancy, followed by labetalol, hydralazine, and nifedipine, and possibly beta blockers. ACE inhibitors and angiotensin type 1 receptor antagonists fall in class D and are contraindicated as their use is associated with cardiac defects, fetopathy, oligohydramnios, growth restriction, renal agenesis, and neonatal anuric renal failure, which may be fatal. For managing portal hypertension, octreotide and beta blockers can be used with safety, while terlipressin can cause uterine ischemia and is contraindicated. Tenofovir and telvaptan are preferred drugs for managing hepatitis B virus infection and can be used safely in third trimester of pregnancy. All direct-acting antivirals for hepatitis C cross placenta and transfer into breast milk. However, direct-acting antiviral combinations show a favorable safety profile during pregnancy. Because of rapid viral decline after treatment initiation and to avoid critical period of organogenesis, treatment may be started at the end of second trimester or early third trimester. Ribavirin is a class extract and is teratogenic and contraindicated in pregnancy. Most immunosuppressive drugs can be used with safety during pregnancy, considering the benefits versus risks. However, mycophenolate belongs to class D drugs and is a powerful teratogen agent associated with increased rate of spontaneous abortion and congenital malformation. Ladies and gentlemen, finally, I leave you with a photograph of the world-class tulip garden of Kashmir Valley. I wish you could visit this world-famous tourist spot and be my personal guest. God bless all of you and thank you for your patience. Thank you. Mr. Chairperson, sir.
Thank you. Now I request Professor Muhammad Sultan Khuroo to add some points in the end of the session. So, final concluding remarks from our chairpersons.
Thank you very much, PSH, for posing confidence in us. Well, there were two talks, very nice. First one, Dr. Adil Bhatt, he just talked about a vaccination in 2.5-year-old disease. Well, there's no doubt about that, that anyone who had been vaccinated had less chances of death, and even in those people who had comorbid conditions. Similarly, he has thrown light that more the vaccinations, the less chances of getting mortalities. And the second one, Dr. Khuroo, he has thrown light on a disease, basically a physiology. Pregnancy is a physiology, but if it is in a diseased mother, it can be lethal. So he has given us a very nice talk on all the things which are possible for a pregnant mother. Thank you very much.
Thank you, madam.
Thanks the organizers for such a wonderful session, and thankful the President Pakistan Society of Hepatology. There were two talks, madam already mentioned. Both were excellent talks, and thanks all the audience who are sitting in late evening time. So thank you very much.
I have just one question for Dr. Adil Bhatt, if I may. Do you think we may need a fifth injection? And the other thing is regarding the different types of vaccines. Are the Chinese vaccines as good as the others? Thank you.
So, Professor Adil Bhatt is not here.
Oh. Right. Right. Okay.
Okay. Thank you, everyone.
Right. Thank you.
As usual, couple of just quick housekeeping announcements. There is a tea break on that session. That's again in Kohinoor, the way we had tea this morning. It has been a long day. We debated a little bit about whether to have the break or not, but it has been a very long day. So we'll have a quick tea break. We'll be convening back in this room for a very excellent debate. And I apologize to Dr. Kaur because he's on schedule, but we are a little behind it. So we'll catch up with it. So please come back. And that session is followed by a very important seminar, which is HCV elimination. And one other thing I will tell you is I'll also be announcing the results of the quiz this morning, right after this talk. Before this talk, sorry. So before we get in. So results they are in. Okay, we'll see you guys in about 15 minutes, please. Same room.